It's called 405 Delivery. There you go. All right, let's start off with the basic stuff. Oxygen therapy. Obviously, whenever we have documented or suspected hypoxemia is the indication for it. We know the causes of it. In this world, especially in the NICU, intrapulmonary as well as intracardiac shunts are a big-time cause of this. Children pretty much follow the rules for adults. When you start getting into newborns, especially premature, we be a little bit less aggressive in oxygen therapy. Somewhere between 50 and 80 is a perfectly acceptable spot to be for a preemie or even a micro preemie. So long as you got a halfway decent SAT around 90, we're happy. Some of the other clinical signs of hypoxemia you may end up encountering, certainly tachypnea and tachycardia. Apnea is a very profound one. Both apnea and bradycardias, unlike adults, this is an indication of hypoxemia in a neo or a pediatric patient. Okay, so when you see an apnea or when you see a bradycardia, first thing you should think of is oxygenation in that patient, which is kind of different than we're used to seeing. All those other little irritability things. Have you ever heard of the term frog leg? Looks like this. The legs look like a frog. Lying there. Some complications, you should be familiar with these. There's nothing really there that is out of the ordinary. That last one is one we got to obviously be cautious with on those patients with hypoplastic left heart or right heart for that matter. And we know that we try to keep them hypoxemic, and I'll talk about that as we go along here. Devices dependent upon the patient's size. Similar things that are present in the adult world are available in the neonatal world as far as non-rebreathers and nasal cannulas. Nasal cannula, you get a little bit of a problem with, especially in the premature child, making sure that you have some mechanism to hold the devices in place and try to couple them, because they're like little worms. They don't like anything on them, so they're going to try to attack it. Which means there's a little sticky there or there to help that out. Usually the low flow is what we end up using, 100% oxygen source. You can also have that hooked up to a blender so that you can go ahead and keep the flow the same, but just drop the FiO2 that is being delivered with that. And you can get flow meters that are calibrated as low as 1/8 of a liter per minute. So you can get a very, very small amount, titrate that down, and go ahead and just wean down the FiO2 in that fashion. Problem with higher flows is that you can get a lot of back pressure. Since they're obligate nose breathers, putting any flow into the nose is going to end up causing the potential for having some inadvertent CPAP. So these are just looking at some of the normal adult devices that we may use in the neopeds environment. We also have the high flow nasal cannulas that has anyone not had an opportunity other than me to use a high flow nasal cannula? Good. Okay. But vapotherm is one example for that. There is positive pressure that potentially is there, so there needs to be a pressure pop-off. These are pretty much been eliminated since we've had the ability to go ahead and use high-flow nasal cannulas. I don't think you're going to see too many hoods being used, although that is an alternative that you end up having. As far as aerosolization, there's different reasons why the depth of particle deposition in neonatal and pediatric patients. They're obligate nose breathers, so there's going to be some filtration potentially there. There's less generations of airways, so there's more chances for inertial impact. They have small tidal volumes. They don't, unless you're able to coordinate them, they don't do a real good breath hold. And this is one of the things that people always want to use blow-by for, and blow-by is not indicated for a neonatal or for a pediatric patient. When they're crying, the argument is always, well, if they're crying, they're taking a breath in. Think about how babies cry. It's a very quick inspiratory phase, and that expiratory phase is prolonged. Well, that quick inspiratory flow that you end up having is not going to allow for deposition to occur. So, I had physicians say, well, as long as they're crying, they're getting the medication. It's like, no, that's not the case. What ends up happening is they swallow it, and then they get sick and vomit all over the place. This is just showing that there's less deposition as you are looking in the younger patients. Per body size, it's not as bad, but if you're looking at the actual amount of deposition quantifiably, it's less as you get younger and younger. We know there's multiple ways to end up delivering this. The heart nebulizer, especially for continuous therapy, is nice, but they're also very loud, and especially in a NICU that can pose all kind of problems. And then you also have the ability to use a pneumatic MDI with or without a holding chamber or spacer, so that's kind of an option to end up having. Vibrating mesher probably end up seeing in most mechanically ventilated patients. We know there's the continuous nebulization that we normally would end up using a breath enhanced. You have better delivery because we're applying that to the inspiratory phase in a greater amount. And then there's the breath actuated, where it's only delivering during the inspiratory phase. Just be aware of the 3 different ways that we can end up doing this. And I don't know, these are just giving the pros and cons of different devices. We've kind of been through these before. Various medications in the neonatal and pediatric range, especially when we start talking about cystics. We have a bunch of different drugs that we may not be as familiar with. Nebulizing tobramycin and colistin, nebulizing Dornase alpha, and hyperosmolar saline has kind of become a new mechanism in cystic patients to try to immobilize secretions, as opposed to just using Dornase alpha. Lots of different airway clearance devices that you probably need to, if you haven't reviewed yet, you probably should be aware of. And there is a kind of a algorithm here. The only 2 diseases that have that have a indication for bronchial hygiene is cystic fibrosis and bronchiectasis. Other than that, there really isn't the best situation there. There are other things that can be utilized, just simply coughing and deep breathing with the patient. These are just some examples, as we said, and cystic fibrosis, there's a whole bunch of toys you can end up using. In the case of neuromuscular disease, we're primarily looking at using not so much percussion, but using postural drainage and using assisted coughing with them. Surfactant replacement, we know that there's a bunch of diseases that we end up seeing. The typical one we end up is the very first one on the upper left side, the respiratory distress syndrome. That's primarily what we're seeing. These charts, by the way, are out of Walsh. If you haven't thrown that book out, it's good. It's a very good book. Primarily, we're using the successes seen with surfactant replacement as the size gets smaller and smaller. And if you're under 1,500 grams, chances are you're doing a prophylactic one anyways, because you have improvement in oxygenations and less barrel trauma present. First dose given within 15 minutes after birth, and there's multiple ones that are there in the market. I don't expect you to know the dose, but it's there if you want to end up having it. It's not benign. There are complications that can occur, and it's questionable of use of being in meconium aspiration or congenital diaphragmatic hernia, even though those lungs are hypoplastic, at least in the case of CDH. There's not a whole lot of proof that it helps out necessarily. The use of CPAP we know is beneficial in respiratory distress syndrome. It's also useful in apnea and prematurity. And then some of the obstructive ones, especially things like tracheomalacia, BPD. There's some other ones that are transient tachypnea of the newborn. Basically, again, when I have a hypoxemia, but no acidosis, I don't end up saying anything else further there. The central apnea is kind of a contraindication. It's not an indication, I would say contraindication. And this is basically saying I have a PCO2 of 60 with a respiratory acidosis present, so probably should be intervened. This is that problem with nasal CPAP. You can see the damage done to the nasal septum just from the pressure sore that ends up being there. So it's not without its downside. Multiple ways to deliver it. Bubble CPAP has kind of become one of the simple mechanisms. I just run a bubbler through and create some back pressure in that fashion. There's also specific devices which can accomplish this. And we only need a really low amount of CPAP to use as a starting point. This is, if you remember back, when you're talking neonatal, you had a gas source through a humidifier, nasal prongs attached monitoring the pressure, and there's some kind of a mechanism to generate. This is just a bubble CPAP, just running some flow of underneath water, and the depth of that hose tells us how much CPAP we end up having. This is the instant flow, or the infant flow, excuse me, that allows for a preset amount of CPAP to be created. It's a little more expensive, obviously. If CPAP isn't working, if we're seeing, increased work of breathing, we're seeing deteriorating acidosis, PCO2s climbing, requirements of FiO2s getting above 60%, 70%, with still not having adequate amount of oxygenation, still seeing some apneic and bradycardic periods, excessive amounts of CPAP. Those are all indications that we need to go to something else. As far as weaning from CPAP, we're going to again wean down the FiO2 to as low as tolerated, even down to room air, and then go ahead and wean down the CPAP level beyond that. And some people even convert them over to high flow nasal cannulas to be able to accommodate them. SiPAP is just basically where you have a level of CPAP and periodically it rises to a higher level, a sigh breath, if you will. And it's kind of like AP or venous sense that you have alveolar recruitment going on. And here's the Viasis SiPAP unit. I don't know if anybody's had any experience with this or not, but it's another alternative you end up having. And you can see what you're basically doing. It's just kind of like a BiPAP breath, where you're rising to a higher level of CPAP and having them breathe spontaneously at that higher level. Mechanical ventilations. Early ventilators, going way back in time, were volume-based. In the early 70s, we started using time-cycled pressure-limited ventilators. These are different than pressure-controlled ventilators. These are pressure-limited ventilators. Currently, the move of all ventilator manufacturers is to have one-size-fits-all. So I can use an 840 in a NICU. I can use an 840 in adult ICU. I can use a Draeger XL. I can use a Draeger XL in the adult or ped. I mean, it really doesn't matter as far as. And some of those modes that we've seen in the adult ICU now are starting to be utilized a little more aggressively in the NICU and certainly the PICU. Things like APRV, things like PAF. So what goes on with time cycle pressure limited, you should be aware of that this is basically one where we're having a preset inspiratory flow. We set a flow rate that has to be significant, that if set incorrectly can be problematic. We set an I time, we set an I ratio or respiratory rate, and we set a pressure limit. The pressure is variable. Even though it's a pressure-based breath, if the flow is inadequate, it's not going to be able to get to that targeted pressure in the inspiratory time desired. So you kind of got to play with it a little bit. It's not like pressure control where it's a expansive amount of flow you have available. This is one where it's a fixed flow rate that we set as part of the setup.
I'm saying that volume, that it's time cycle, and then you set flow rate.
Because I'm not delivering a fixed volume.
You're saying a flow, and you're saying a specific time, how they're going to use it specific time.
Because depending upon compliance resistance, the volume will change. Unlike in a volume-based breath, when compliance resistance changes, the volume stays constant. don't know where else to go with that. With it, just leave it at that. If you remember back, a time constant is just the compliance times the resistance, and that's the time that is necessary to fill or empty. Normally, we need at least 3 or 4 time constants to be able to adequately fill and empty, more empty in the case of a lot of obstructive processes. So normally, if we put a inspiratory time of about 1/3 of a second, we should be okay in the majority of cases. In some cases, with RDS, for instance, you can get by with shorter I times because they're going to deflate quicker, so you don't need as long of time to inflate them. Triggering becomes a real issue with these, especially with the micro preemies. They need a very fast response time, and especially if you have a flow sensor that is being utilized, if that gets contaminated with secretions, it can lead to some problems with triggering. Pressure triggering is difficult because they have a very compliant chest wall, and a lot of their negative intrathoracic pressure that's created is transmitted across that wall, and the pressure trigger sensor never picks up on it. So we've looked at other stuff. Well, how about if we put a sensor on the abdomen to notice when the abdomen is moving and use that as a trigger mechanism? It actually can have an abdominal movement prior to there's actually any airflow happening. We've looked at impedance, and now the latest one is to use a nasogastric tube that has sensors above and below the diaphragm to identify diaphragmatic contraction. And I don't know if you've had a chance to see NAVA and work. It's a neat idea. The downside to NAVA is that you got to drop a specialized nasogastric tube. And they can get a bit expensive. So, nice idea, but I don't know that it's the end-all be-all necessarily. I don't expect you to necessarily know all of these next few slides, but I would like you to know the initial settings for the premature infant. So we're looking at very short I times, very small tidal volumes. And need to pay close attention to the FiO2 as far as what we're doing with the ultimate PaO2 because of the problems with retinopathy of prematurity. And then these just go up, and for the most part, when we get to the child, and I'm going to change this from 7 to 10 to our 5 to 8. Walsh had it as a little bit higher. I think in most PICUs, if you look at them, they're using tidal volumes that are pretty much the same as you would end up seeing elsewhere in the world. 5 to 8, yeah. Again, I'm not a pediatric therapist, but I think for the most part, if you talk to people who work peds, they'll tell you 5 to 8 is kind of the ballpark they're using for everybody nowadays. A little bit longer I times, almost back to where we were with the So look at preemie, look at child as far as settings, and then adolescent is basically back to adult. We know that we're going to try to look at using the frequency as our primary mechanism, but again, be careful at high rates in the presence of air trapping. Most ventilators compensate for compressible volume, but it becomes far more important in this population than it does in the adult world, because in the case of a neonate, you may be talking about a tidal volume of 5 mLs. Well, any kind of dead space or compressible volume is going to be huge in that world. As far as PaO2, you guys know we can use the FiO2 setting. However, we typically look at the mean airway pressure, and there's a formula for it if you really need to. If you're calculating mean airway pressure, you must have a lot of extra time on your hands. All the ventilators now have the display of that value, but you know that those things on the bottom there are all affected. So manipulating mean airway pressure is something you should know how to end up doing. And we talked about compressible volume. Air leaks, usually they're uncuffed tubes, so there is going to be some degree of air leak there. Mechanical dead space is critical. Airway resistance is critical. The use of an HME If that HME becomes clogged at all, it's going to manifest itself a whole lot more in this population than it would in the adult population. And humidification becomes critical. Complications of ventilation, shouldn't be anything there that you haven't encountered as of yet. Looking at high frequency, FDA says anything over 150 is classified as high frequency. There's 3 primary ones that we see, although 2 of them are really utilized nowadays. High frequency flow interruption was one of the early ways of ending up doing this. High frequency jet and oscillatory are the 2 that we primarily see nowadays. How it works, I don't really care that you know. It ain't the way that we normally ventilate though. It's not bulk movement in and out. There's got to be some other way of doing this when we're using tidal volumes less than anatomic dead space. And there's 3 theories that are there: the spike formation, the helical diffusion, and tailored dispersion. There's also what's known as pendulift ventilation, where you end up actually having ventilation occurring during exhalation, so air is moving in opposite directions. This is the spike, where you end up having the flow. This is the helical, where you have the flow going down and exhalation coming up along the outside. And tailored dispersion is kind of along the same line, where it's a different type of breath that is being utilized and how it's delivered. Here's the pendulift, where you end up having gas moving in all directions. And yeah, we'll let it go at that. What on this slide should you know? That bullet point there, changes in respiratory rate at a constant pressure yield a counterintuitive change in tidal volume. So when you go up on your rate, you actually go down on your volume. So it's kind of back-asswards. When you're in high frequency ventilation and you want to lower your PCO2, you go down on your rate. It seems counterintuitive, but that's the way it ends up working. Oxygenation is primarily due to alveolar recruitment. We're operating at a higher mean airway pressure and oscillating around that mean airway pressure. So it's important to keep the mean airway pressure constant. This is some of the settings we would end up setting. We set a frequency. Normally we start off with somewhere between 4 and 15 hertz. So we're talking of rates of 240 to 900. Very fast breaths, obviously. We set an oscillatory amplitude, which is basically the delta pressure that we end up having. This is what determines the tidal volume. In jet ventilation, we actually set a pressure. In high frequency oscillatory, we just set an amplitude. There's a baseline pressure that is there. There's an FiO2, just like you would normally see. And then we have a mean airway pressure that we want to oscillate around in the process. Normally we have on the oscillator have an I time of roughly 33%, so you have a 1 to 2 ratio in the process. On the left you can see the Bonnell jet ventilator. On the right is the high frequency Sensormedics 3100A that you end up encountering in the NICU. These are low compliance circuits. They don't have a whole lot of distendability to them. Sometimes, especially in the case of a jet, you end up having a specialized endotracheal tube that allows for some humidification to be dripped in, because humidification is a problem. Typically, we end up using these after conventional ventilation has proved to be poor. Jet ventilation works great for air leak syndrome. So pulmonary interstitial emphysema, bronchopleural fistula, high frequency jet works well for that. High frequency oscillatory is more for oxygenation problems. Your typical RDS that is non-responsive to conventional ventilation. And you're seeing more and more where we're using this not as a rescue but as an actual therapeutic intervention, not waiting until the lungs have been badgered for 4 days, immediately going to it as an intervention if the indication is there. A couple different approaches you end up having. You can have a patient who has atelectasis. We may use a little bit higher descending pressure to get those airways open or the alveoli open and minimize the amount of de-recruitment you have. In other patients, because of the air leaks, we may use a low volume strategy and just have that permissive hypercapnia there and allow that overdistension to be minimized, because that overdistension can end up worsening any kind of leak you may have. Non-invasive, because we end up having chronic failure in patients with BPD, patients with CF. We also see it utilized in patients with neuromuscular disease. Same kind of settings you're used to seeing in the adult world would be used there. Same kind of interfaces, although you do see some changes in bone structure as you end up having chronic use of the mask. So it's not without its problems, the bottom line. Only contraindication is cardiovascular instability, or I should probably change that to say the need to be mechanically ventilated, the need to have an airway in place. But there's some other complications that are present there. Nitric. Should be aware of what goes on with nitric oxide. Again, it's a selective pulmonary vasodilator. We mix it with nitrogen in an 800 part per million concentration. And you can see on the right hand side you have a normalized alveoli there, and you have perfusion. If I have a situation where I have some pulmonary vasoconstriction present, secondary to hypoxemia, imagine this being a collapsed alveoli on the bottom, we're not oxygenating. This is going to vasodilate those the pulmonary capillaries that have good alveoli there. Because it's an inhaled gas, it's going to react and increase increase perfusion to those well-ventilated areas. So it's a selective pulmonary vasodilator. It vasodilates those capillaries where there's a good alveoli there. So it optimizes the VQ relationship. Does that make sense?
You say most common concentration 800 parts per mil. That's where it comes out.
Yeah. That's preset. So our dose is only going to be 20 to 30 at their starting point, and usually when you get up above 80, you're probably need to look at something else. We monitor not only the nitric oxide concentration, we also monitor the nitrogen dioxide, the NO2. NO2 is a byproduct when oxygen and nitric oxide mix. It's toxic, and usually you see it when you have high oxygen concentrations, which is probably why we're using this. The other problem is that nitric oxide also forms methemoglobin, and as of right now there's only one manufacturer of this, and buy your Datex Omega stock because they got a corner of the market. Heliox, know about this, has less density. Again, it doesn't treat the obstruction, but allows us to ventilate around it. Usually we use either an 80-20 or a 70-30, and you know the factors involved there. You can do with a spontaneously breathing patient using a non-rebreather. This is all stuff we've seen previously. Problematic with a ventilator. There's a handful of them out there that do have the ability to utilize Heliox delivery because the flow mechanisms don't get disturbed as much. We basically just use Heliox as the air side of the 50 psi inlet. Hypoxic and hyperoxic. We know that oxygen is a pulmonary vasodilator. There are times when we'll put a patient on a low FiO2, 17, 18%, to keep the PDA open. This is the example being hypoplastic left heart, where when that PDA closes, the child gets into a huge amount of problems. We also have the knowledge that carbon dioxide is a pulmonary vasoconstrictor. So in some cases, we may want to, if you can't go up on the FiO2 anymore, you can keep the PVR up if that's what the desire is, by having the alveolar hypoventilation going in. So using both gases in contrary to what we would normally use them as. ECMO, vast majority of the patients, if you look there as far as the use of them, is with neonates. And look at the survival. 94% of MAS when ECMO is used. So it's tremendously beneficial. RDS, yeah, some good success with it. Congenital diaphragmatic hernia, not so much. It's because the lung has been damaged for so long. And CDH is the one that they're actually trying to do intrauterine surgery prior to delivery to be able to repair it so that you don't have the lung being in the developmental stage and being collapsed. Pediatric ECMO is not as successful as neonatal, and if we look at adult ECMO, it's even less so. But still get pretty good numbers on pneumonias and aspiration pneumonitis that you end up seeing. Improved outcomes, to say the least. Selection criteria, you should know that the OI should be greater than 40. It should be a reversible process, not lung cancer. They typically will not do it if the neonate has a IVH. It's questionable benefit. And certainly coagulopathies become a relative contraindication just because of that. And there's your formula for the OI that you should be aware of. FiO2 divided by PaO2 times the mean area pressure times 100. Some other indications. This is out of U of M's ECMO protocol, and you can see they're pretty much along the same line as far as their criterion. Contraindications, that active bleeding again is a relative. The absolute, things like brain injury, things like terminal disease. Obviously that's not the issue. So what we're doing is basically taking part of the patient's own blood flow and redirecting it in the veno-arterial, which is the I'm going to say it's less common, but basically we're cannulating the right atrium, we're cannulating the internal right common carotid. So we're pulling blood out of the right atrium through the IJ and putting it through the oxygenator and then putting it back in. So 80% of the blood flow that's going through is going through the oxygenator, and the amount of blood PO2 that is there is how much the native lung, because there is still some that the lung is contributing, and some of the cardiac output. And this is the disadvantage and why we try not to use a veno-arterial route. You got to ligate the carotid artery after the fact. And kind of not something you want to necessarily do. And here's what we end up seeing going on. Arterial cannula coming from the carotid artery, dumping blood back into. Venovenous is your other option, where you're pulling blood and you're returning blood in exactly the same spot. Where ECMO has some cardiac support, venovenous does. Where veno-arterial ECMO has some support of the heart, venovenous does not. Venovenous is strictly just pulmonary support. And there is the potential for some of the blood that you just oxygenated and put back into the venous system being pulled back in and being re-oxygenated again. It's kind of a recirculation back to the oxygenator. So again, there's no cardiac support, and you can see the double lumen cannula here. This is where I was talking about. We're dumping some of this good oxygenated blood back into the right atrium, and there's nothing to prevent it from being pulled right back up again. This is the ECMO circuit itself, regardless of if it's arterial or venous, we're putting it through a heat exchanger, through our oxygenator, and then through a pump, pushing it back in again. I don't know if you really need to know anything more about that. If you ever wanted to be trained in ECMO, that's something that typically sites that do ECMO will do specialized training. This is just kind of looking at what the membrane oxygenator looks like. You're basically having a higher oxygen on one side than the other. It's going to go ahead and push the oxygen molecule across into the bloodstream. We monitor the mixed venous oxygen in the case of the veno-arterial. Coagulation is critical. We also got to watch the pump itself has the ability to chew up platelets, so we got to monitor the level of platelets, monitor their fluids. Ventilation really becomes less important because I can control oxygenation and ventilation with the ECMO circuit itself. Normally they're only on for a short time. We try to either wean the amount of ECMO support and increase the amount of support from the ventilator, or just basically do a stop the ECMO and let's see how they fly on their own. And lastly, last weekend I had the fun time of taking a PELS course. For years I had to put this off, and it's like, after taking it, it's like, what was the big deal? Everything I taught you having to do with preload, afterload, contractility, shock states, it's all PELS. Very, very simple. I'm going to hand out this sheet. Maybe. I don't trip and fall in the meantime. This is the sheet they gave the study guide for us. And it's set up very, very simply. The initial part, you're doing an initial assessment. Then you go into a primary assessment, A, B, C, D, E. Then you go into a secondary assessment where they use the mnemonic sample. And then you go and you look at some other diagnostic tests. And flip on the back side, there are basically 12 different scenarios that they would do as far as like a mega code, where you guys will have, who's at Children's? Am I bugging you? Okay. In the adult world, there's fewer scenarios. Here, there's a little bit more. You're always going to get one of 4 different respiratory scenarios, or one of 4 different shock scenarios. Cake. If you identify them being in circulatory shock, or you identify them as being in, cardiogenic shock, or you identify them in hypovolemic shock, you guys know how to treat that, right? So it's not as big of a deal. And in their cardiac arrest, most arrests are due to hypoxemia. So even in the case of a symptomatic bradycardia, when the heart rate's less than 60, what do we do? We do CPR. We give epinephrine. It's like, wow, that's really different than the adult world. But again, most hypoxemia, or most bradycardia, is secondary to hypoxemia. So we got to work at doing effective ventilation. The dope mnemonic that you see on the lower left on that sheet, that's something that you should be aware of as far as a mechanism by which you can, if you don't have the ability to adequately ventilate, this is a sequence that you can follow to be able to determine, is it something where the tube is displaced, either into a mainstem bronchi or it's outside the trachea? Is the tube obstructed? Can I pass a suction catheter? Are there secretions or kinking of the tube present? Either simple or tension pneumothorax is the P, and equipment failure is the last one that is there in the process. So I encourage you to take a PELS course if you're bored. I was putting it off for nothing. It was pretty cake. And now I need to become a PELS instructor. That's all that's left. So again, just distinguishing between respiratory distress and respiratory failure. So long as they're able to move air, may not be the best situation, but the respiratory distress, if they're totally unable to and they need ventilatory support, then that's respiratory failure. Some of the signs of respiratory compromise, shouldn't be anything there. Head bobbing, very common in neonates that are having difficulty, or infant children. Seesaw ventilation, where the abdomen and the chest wall are going in the same direction. These are just some general appearance changes that you end up seeing. Normally, these is the left-hand side when you don't have the right-hand side being there. This is just kind of that rapid cardiopulmonary assessment, the ABCDE we were just talking about. And knowing the different sounds that you end up having, the presence of stridor typically implies an upper airway. The presence of wheezing typically implies a lower airway. The other two respiratory disease states that you ended up having there, lung tissue disease. What the hell is that? It's pneumonia. So where you end up seeing the presence of crackles, presence of wheezing. And in disordered control of breathing would be one where the ventilatory pattern is not rhythmic. It's very sporadic. And then looking at circulation, some of the different stuff you can end up identifying. You should know nothing there should be that difficult. I won't ask you normal heart rates or normal blood pressures. By the way, the blood pressure that they utilize, and you have it on the sheet there, there's a range of blood pressure that a child of various ages between 1 and 10 should be at. The lower level is 70 plus their age times 2. So if I have a 6-year-old, that means that 6 times 2 is 12 plus 70 is 82. The minimum blood pressure they should have is 82. On the high, what was considered the high end is 80 plus that age times 2. So if they're above that, we're considering a normal blood pressure. It's that in-between range that we're going to call compensated shock. So in other words, their body is trying to compensate for the fact that there's a problem there, and we need to intervene in a quick range. So that's what this little middle range is talking about, that compensated shock. But you can see, who wants to memorize this? That'd be awful. I don't know what this is supposed to mean. Always assess your patient. This is, last week I forgot I had a test. It was all multiple choice, so I answered AC/DC down the whole page. I got the test back and I got 87%.